Hi, everybody. Thank you for joining, and there'll be definitely more people going to join in due course. This is the first session of this year 2025. We have Dr. Nitish Pratap sir from KIMS Hyderabad, who is kind of more like a friend to me now than as a mentor. Initially, I went to Hyderabad to learn a lot of nuances in biofeedback therapy from sir. Thank you, sir. Thank you for all that you have taught us. And the biofeedback therapy cannot be complete without mentioning your name. You have started a new protocol called KIMS protocol in anorectal biofeedback therapy. So it gives me great privilege to have you and share this podium with you, to introduce you and to host this session and to talk more on this topic. The topic is on nuances in biofeedback therapy, which would last approximately half an hour to 40 minutes, followed by a Q&A session. So the podium is yours, sir. Please go ahead. Thank you, sir. Thank you for it's our privilege to have you here.
Thank you, Prashanth. Thank you very much for inviting me today. And I would like to also thank the Ready Stock team for the help. They have helped me for this. So let me start with saying that I want this to be a very informal thing because the main purpose of today's meeting is to understand what problems you are having with biofeedback and what are the things we can help from our thing to help you to do it properly with the patient health. So my talk will be covering two sets. The first one will be in pelvic floor dyssynergia. So we all know that patients with pelvic floor dyssynergia will have typically prolonged straining, feeling of incomplete evacuation, more stool frequency, digital evacuation. And in these patients, when you do a manometry, it might be abnormal, balloon expulsion is abnormality in 50%, defecography abnormality in 61%. The Rome 4 says that at least two of these three criteria should be there for you to diagnose the patient with pelvic floor dyssynergia. So before we go into biofeedback, we have to understand that what is a basic problem which these patients have. So we are looking at two components. One is the propulsive force and other is the relaxation of the sphincter. So in these patients with functional defecation disorders, either the propulsion is not good. That means they are not able to generate the rectal push to get the stool out, or they are not able to relax or paradoxically contract the sphincter when they are defecating. So these are the things which we will aim to correct when we are doing biofeedback. Now, the types of pelvic floor dyssynergia have come in the London classification, but I have been using for a very long time this classification which has been given by Satish Rao, Dr. Satish Rao, because I feel that this helps me to plan my biofeedback easily in these patients with pelvic floor dyssynergia. So as we all know, type 1 pelvic floor dyssynergia is a very classic case in which the patient is able to generate good rectal pressure, but there is a paradoxical anal contraction. So when I am planning a biofeedback in these patients, I know that here they are able to generate the push, but they are not relaxing or in fact paradoxically contracting the sphincter. So here I'll be more concentrating on relaxation to them rather than only on while the second group, which is the type 2, here they are not able to generate the push and the paradoxical contraction. So here I have to work both on the rectal sphincter relaxation as well as the pull. So it is not that I won't put all, but I know which component I have to implicate more when I'm going ahead. Type 3 is something in which they are generating adequate rectal pressure, but the sphincter is not relaxing. Here, only difference is they are not paradoxically contracting it, but the sphincter fails to relax. In type 4, it is both both rectal push and sphincter is failed to relax. So based on these, I will first plan in my patient how I am going to do my biofeedback therapy. So basically, we all know that in biofeedback therapy, you are going to tell the patient how to coordinate the muscles during defecation so that the abnormalities which we have seen are being taken care of. So this is how a typical manual training we keep a monitor in front of the patient so that he is seeing what is going on, and then we will tell him all the different things how to go about. So basically, the first part is very important. I think the most important is that the patient has to understand that where they are going at. So, where the so that they and explain to them the basics of how they are going wrong when they ask the food. And also, let's look for the next few steps regarding the involvement of patient explanation. So, the main objective of the first part is to make them understand, like the patient.
So the first part I usually do when I start my biofeedback therapy is the relaxation, because most of the patients who are having pelvic floor dyssynergia are either contracting paradoxically or not relaxing. So I make the patient as if normally the lateral position in the manometry with the system in front of them, and I initially ask them to just contract the sphincter for a few seconds so that they understand which muscle they have to relax. After that, next slide. Please play the video. Next slide. So what I do them is I ask them to just relax the sphincter as if they are not and continue doing deep breath. So what happens is when they are doing next slide, when they are doing deep breath, and I ask them to relax. The second component which I use is to increase the push of the patient. For the push of the patient, I use three maneuvers. One is the breathing. Second, I ask them to tighten the abdominal muscles. And the third part is push. So when I start my biofeedback, I divide it for a patient with pelvic floor dyssynergia. I divide it into three components. First 15 minutes, I just ask them to just learn to relax the sphincter. So they are doing nothing, but I tell them to make it as light pink as possible. Once they have understood how to relax the sphincter, next my 1 hour session is divided into these components. Next 10 minutes, I ask them to just take deep breath and relax the sphincter. I always say that you have to be see to it that there is no black color coming in the sphincter area, and there is no change in the pressures in the rectal, or they should be relaxed. So the next 10 minutes, what I do them to the patient is take deep breath and reduce. So you can see in this first video, when the patient is taking deep breath, you can see the rectal pressure is going up. So once the 10 minutes they are coordinated with this, next what I do with these patients is that I ask them to tighten the abdominal muscles so that they increase the intra-abdominal pressure, keeping the rectal sphincter relaxed. So this is for the next 10 minutes. So it is like I keep them a 60-second window in which I ask them to tighten the initially for 5 seconds and then give a 30-second break, and with time I gradually increase. So first 10 seconds, first 10 minutes, my patient will be only doing deep breathing, abdominal breathing with rectal relaxation. The next few minutes, next 10 minutes, it will be abdominal tightening of abdominal muscles with rectal relaxation. And the next 10 minutes is I ask the patient to bear down as if they are passing stool, that is simulated defecation, while keeping the sphincter relaxed. So the next first 15 minutes I dedicate only for relaxation. Next 30 minutes is for these three components. First is breathing, keeping the stool relaxed for 10 minutes. Take abdominal muscle tightening, keeping the sphincter relaxed for 10 minutes. And push down, keeping the external sphincter relaxed for 10 minutes. Next slide. Next slide. Yeah. The next thing, back, sorry. Next, what I do is apart from this, other is I ask them for sensory training, especially if their sensation is not very good in these patients. What I do is I ask them. We put with inflate the rectal balloon with 60 cc and ask them for first sensation. And whenever they have a sensation to pass stool to push down. So what happens with time? They will get a little sensitized to this, and the the sensitivity towards the pelvic muscles improves. The last half an hour means now the last 15 to 20 minutes of the 1 hour session is for the coordinated stimulation or simulated defecation. In this group, what I ask them is to first relax the sphincter for 20. So here I keep a watch of 20 60 minute second window in which I ask the patient to first relax for 10 seconds. Then I will ask them to take deep breath, tighten the abdominal muscles, and push down for at least 10 seconds. And keeping the sphincter relaxed. Normally, most of the books say that you ask the patient to push down and then ask them to relax. It is very difficult to do that. So, what I have realized is that so I ask them to relax first and see to it that there is no contraction or paradoxical contraction in the anal sphincter. And then I ask them to take deep breath, abdominal muscle tightening, and push down. And with keeping in mind that they have to see to it that the sphincter doesn't contract or there is no paradoxical contraction. So in this way, hello, can you hear me?
Yes, sir, we are able to hear you. Please go on,
Yeah.
sir. Yeah.
So in this way, what we do is the patient will be able to at least understand how to relax and push down. And my main concentration on push and relaxation depends on whether the fellow person is having more of a problem in push or more of a problem in relaxation. Next slide. This usually I give 1 hour sessions initially bi-weekly and then 3 to 4 sessions. Usually most have got type 1, and once they understand where they are going wrong, they will usually get a good response. Next slide. Next. I'm sorry because these are my initial slides. They are all jumbled up because my presentation there's some issue here. So if you are looking at these patients in biofeedback with pelvic floor, I feel it is a very good modality. Only thing we have to understand that each patient is different. Each patient has a specific problem, and I think we have to address that problem properly. So if we understand what is the basic mechanism and try to correct it, the response is very good. Our PG has done a thesis in which we have had a response rate of around 75% in properly selected patients with pelvic floor dyssynergia. And there is good improvement in their constipation scores and overall improvement in their lifestyle and on. Next slide. So, Prashant, should I stop? You want to us to, we'll have any discussion on this or we'll discuss in the end?
Sir, I think we'll discuss in the end. Question keeps
Okay.
gathering and then we'll go ahead so that there's
Okay.
clarity. Sure, sir.
Okay. So the next part is biofeedback therapy for fecal incontinence. So we all know that incontinence can be because of abnormality in the sphincters, neuro, rectal compliance, transit problem, or stool consistency. Next slide. So in uh, pelvic floor dyssynergia, we are training our patients to push properly, to sphincter relaxation. Here it's the other way around. Here you have to ask the patient to voluntarily squeeze so as to regulate the continence. So it's the other way you have to look at this. Mainly, I look at patients who have got sphincter without major sphincter defects. Sometimes some patients come to us after a sphincter repair, which is with results not optimal. Next slide. So, next slide. The most important part in the is the correct selection of these patients who have fecal incontinence. I personally feel that if a person has got a fecal, I do a sigmoidoscopy in these patients to rule out any structural thing. I do manometry to look for how are the pressures. I usually do an endoscopic ultrasound in these patients to look for sphincter integrity. Because if the sphincter is too much damaged, then in these patients, biofeedback won't help. For them, I send them to surgery. When I am doing biofeedback in incontinence, I am looking at three different components. One is the motor skill training, in which I am trying to strengthen the muscles. Number two is the sensory training, in which I will increase the sensory perception of the patient. And third is the coordination of all these. Next slide. Next slide. So, so the main aim here is to sensitize the patient about how we are going to reach the objective of continence from incontinence. Next. So here you have got basically three protocols. First is the strength training. This is nothing but you are exercising the external anal sphincter without rectal distension. Second is the sensory training. This is very important in this group because this sensitizes these patients for small volumes of rectal distension and helps them to maintain continence. And third is the coordination. That is, the patient contracts the external sphincter to rectal distension. Next slide. Now, in rectal training, the main aim of our training in these patients is to strengthen the muscles. So here you don't do anything. What I ask them is that I ask them to do a long squeeze. I ask them to voluntarily squeeze the external sphincter for 20 seconds, relax for 40 seconds, and this I do repeatedly. So first 20 minutes of my thing is in a patient with mainly the squeeze. So I ask them to squeeze 20 seconds, relax for 30 seconds. So this goes on repeatedly. Next slide. The next uh, the next part is the sensation. The main aim of this sensation is to achieve normal sensory threshold. So here what happens, you inflate the rectum and ask the patient to tell us when they first feel the sensation. So, what happens initially, for example, this patient, when I started, the first sensation came at around 130 or 140. But with time, they will get sensitized. So, they will be able to pick up lower volumes with time. So, this is very important. So, this I do repeatedly with them so that they sensitize to that sensation of something getting full in the rectum. That is the first sensation what you are looking at. Next. The third component, what I look at is that is coordination training. In this, what happens? I put in here, I tell them that once they feel a sensation that they are going to pass stool, the urge to pass stool, I ask them to contact the external sphincter. So here you are basically coordinating, adding both first and the second component to the third one. So my normal thing is 20 minutes, 20 minutes, 20. This is how I do for my fecal incontinence patients. Next. So it's the same sessions, 1 hour bi-weekly with 4 to 6 sessions, and based on the patient requirement, I will be changing the number of sessions required. Next. So, the most important thing for us to understand in a patient with fecal incontinence is that the response to therapy is poor if there is a major damage to the sphincter. So, if your sphincter is damaged, then it is no use of doing a biofeedback. So, these patients with severe damage, better to send to surgery. Major sensory, if they are not able to get major sensation, is not that it's difficult. And if the pressures are very low, these are the groups whom the outcomes are not very good. Next slide. And if you do a proper selection, the success is very good. Almost two-thirds of the patients have got around 75% decrease in fecal incontinence, and 50% remain continent for more than 3 years. But you have to remember that though your sphincter pressures will not change, this has been shown by multiple studies by Dr. Satish Rao that though your basal pressures and squeeze may not have a drastic change, but once they exercise, the patient is able to maintain the continence. Next. Next. So I think, we had last. Okay. So I will conclude by saying that biofeedback is one of the very important modalities we have in our patients who have pelvic floor dyssynergia as well as fecal incontinence. I feel in patients with pelvic floor dyssynergia, this is the mainstay of treatment. And if we do it properly, the response rates are between 70 to 90%. When you come at fecal incontinence, it is very important that you select your patient properly for biofeedback. Do your proper workup before you take the patient for for thing. Patients with a severely damaged sphincter, better to send for a surgical thing. If a patient has got a sphincter which is intact and you do a proper biofeedback, the results are more than 75% success. Okay, thank you. Okay, Prashant, over to you.
Thank you, sir. Thank you. Despite the interruptions, the videos, usually the coordination for us to know what exactly is done really makes a huge difference for us, sir.
Then
So
I'm sorry, I sudden some issue happened here.
no problem, sir.
Mhm.
The talk was really, really informative, especially from the perspective of what is exactly done and how
Yeah.
differently you're doing it, and what happens from a video perspective in the manometry. What are the changes that are happening now? That was the real goal of the today's topic. So, great job, sir. Thank you. So, two most common problems. One is constipation and fecal incontinence, where biofeedback really plays a role, has been elucidated quite clearly. So, sir, just to be more clear, I'll go ahead with question and answer session in a while, just to know the nuances. When a person comes with chronic constipation with an history that is probably suggestive of anorectal dyssynergia. First, we tell the type of anorectal dyssynergia as it is one among the four types. Sir, what is the most common type that we see? And from a biofeedback therapy, how do we select that this patient, what are the predictors for us to tell that biofeedback therapy is going to help the patient? And then based on the four types, how slightly do you change your approach and give predominance to which component during the biofeedback therapy? Like you have said, the different components that you will teach them how to not contract, that is to relax the first significant time. Now, that is followed by breath and its coordination with relax.
Mm.
Then comes
Yes.
abdomen pressure with its coordination, and then comes the push. So these are the
Yeah.
four steps, and finally you are going to coordinate everything. So I would want to know, most importantly, with respect to the four types, what are the some uh, tuning effect that you do for different types, sir, of
Tell
anorectal?
you. See, the most common type what we see is type one, and I feel that type one respond best to biofeedback because what I have seen in my experience is that most of these patients have had a constipation previously. They had a fissure that has become painful, and with time they have gone into this holding, and so once they understand that okay they are contracting instead of relaxing, these are the patients who respond very fast. If you are looking at the patients who have both problem in push as well as the sphincter relaxation, they take time. Young people, they are very fast. Patients who are elderly, they take time. This is what I have realized, and the sensation has to be intact, otherwise it's very difficult. The the changes I do when I'm looking at these four is, suppose the patient is having more of a paradoxical contraction. In these I will go for a long time, like if I'm giving a 1 hour session, 30 to 40 minutes, 30 minutes I leave him for relaxation. I'll ask them to do breathing exercises with just relax. Then around 15 minutes I'll give that push so that it helps them. Suppose it is the other way around, then I will make my session like 15 minutes relaxation, 10 minutes of breathing contraction, then abdominal 10 minutes, push 10 minutes, and quadratic. So my half an hour will go more to push if there is type 2 or type 4, or 1 and 3 it will go more to the relaxation part.
Yeah, sure.
So it is the duration which is different, though I do the similar in most because it helps them.
Sir, when we say relax,
Hmm.
is it just about the color that from black try to make it pink, or first sensitize them that you squeeze now, this is contraction, now you are not supposed to do it, that is relaxation. It's so difficult to just relax, sir. So please, this is one issue.
Yeah. Basically, you can't relax. You don't shouldn't contract. So what I tell my patients is always when I start, I say first tighten it. Then I show them कि this is the muscle on which you are going to work now. So once they tighten it, they know that okay. I ask them to always before my session, my first 5 seconds, I tell them you first tighten the muscle so that you understand how you are doing, you understand which muscle you have to exercise, and then I ask them to relax. So my main aim is that first I ask them to contract, because that's very important, Prashant, because you ask them to relax, they will not understand which muscle. So, and I tell them that it's not that you can open it, I say that you just leave it loose, do not contract it. This is what my instructions are to them. So initially I ask them, you contract, then leave it loose and see to it that is in the light pink shade, and and try not to contract. This is what my instructions are to the patients.
Great, sir. Okay. Sir, when it comes to fecal incontinence, like, what is the role of risk stratifying that this patient is best for biofeedback therapy? Like, is it only EUS where there is sphincter that's a problem, or there are other predicting factors that a patient, the shayad biofeedback, there is a better response?
Yeah, basically I am looking at three components. The first component, that's why I look at basically whether the sensation is there or not. Agar sensation is not there, it's difficult. Sphincter damage, very bad response. If the pressures are especially very low, very bad response. So these three groups I feel is very, that's why I add, if the patient has not been properly worked up previously with the proper sigmoid or a manometry and all, so those are other group. That's why I feel that you should properly investigate and then only characterize whether he's fit for biofeedback or not. So sensation and sphincter integrity, these are the most important two things which are to be taken into consideration before we go ahead.
Okay, these two important factors. Sir, we have also, when we are reading, we read a lot about pudendal nerve latency,
You can
or
see, yeah.
new guys come up with telling there's electrical, some physiotherapists are there telling there's a new electrical stimulus, we can do this.
Yeah.
We're really confused, sir. Of course, manometry is what we trust, and we have complete control over what we are doing. Now, these new ones are coming with electrical therapies, and
Yes.
how to put them
Actually,
in.
in Hyderabad also two people are doing, basically it's the same thing. Here they'll have one electrode in the rectal area, one of the abdomen, and they'll see to it that the coordination is there. It's same, the biofeedback is same. Here you are looking at the manometry, there you are looking at the pressure changes. And pudendal nerve latency, this is helpful in some patients. This nerve stimulation in patients with biofeed in fecal incontinence, with especially neurological thing. Here in I think in AIG they are doing a lot of work on that.
Cool. So, how we see manometry and biofeedback, also the electrical physiotherapy that some of them do also is probably equally effective, or
Yes, yes.
okay, it is quite effective. Cool, sir. Sir, question from Bangalore, Dr. Manmohan has asked, how many minimal, like, how many sessions of biofeedback therapy is minimal for a
Basically, if you look at the articles, and they say that at least 4 to 6 sessions, and minimum at least 1 or 2 times a week, 1 hour sessions. But what I personally feel is that it is basically the patient's response. Suppose if it is type 1, the patient understands if you do it 1 or 2 sessions, Third session, they will not come back because they know where they are going wrong.
Mm.
So no, I recommend usually 4 to 5 sessions minimum. But if the patient is having good response, they have understood the physiology, what they are doing wrong, then usually 2 to 3 sessions might also suffice.
Thank you, sir. Second question, what they've asked is, okay, what is the general cost we can charge per session, considering it's almost 1 hour? I know it could be a more diverse answer, but then probable per session, how charges are done generally, sir?
No, it is variable place to place, but I think because you are giving almost 1 hour to the patient, I think it is varying between 5 to 10,000 in most of the places.
Per session, sir?
Yeah.
Okay. Second, sir, Dr. Samit has asked, some patients have difficulty in localizing sphincter even when told to contract. How to deal with them? When you say you ask them to take deep breath and coordinate, what do you exactly explain to them and how do you go about it?
Yeah, and I'll tell you. So it's, see, basically you have to tell the patient initially that suppose you are in a outside and you are getting a stool, how you are going to stop to pass stool, do like that. Most of the time they understand this language, that you are outside where you do not have facility to pass stool, how we are going to do. And once they contract, you show them on the on the screen the rectal pressures becoming high, sorry, the sphincter pressures. So that it takes some time, because some few people take some time to understand what is going on. And usually with this, most of them understand because you are showing them the sphincter, and also you are showing the changes in the pressure on the manometric graph. The second question is, I ask them that when they are breathing, I ask them that the pressure in the rectum should increase, because I showed you in the video, I couldn't show because I couldn't play from my flow, but I asked them to see to it that the pressures should increase in the abdomen. In the rectal pressures, if you take deep breath, definitely it increases. You can see that change very clearly when you're doing biofeedback. So I asked them to take a deep breath, and I see to it that I tell them that when I suppose I am starting them with the breathing part, I say first tighten karo, then I ask them to relax. I say that now this sphincter, they should no black line should come in this. It should be light pink. You have to leave it loose, and you have to see to it that you don't contract. And then I ask them to start the breathing. So whenever I'm doing my thing, first 5 to 10 seconds will always be relaxation. After that, it will be the breathing, whatever I'm adding on to that. So the first 10 seconds, I ask them to first tighten for 1 or 2 seconds, then relax for 30, and then start breathing. And my instruction to them is take deep breath and see to it that the sphincter should not become tight. And on the screen, the pressures should be on the light pink range.
Okay. Sir, very well told about the coordination part, sir. Now, when we still deep breath, some of the patients or even we are confused, like, should it be an inspiratory chest rise and then while
So abdominal rise.
abdominal? So that is
It's an
one thing.
abdominal breathing.
Now we
Yeah.
see many patients doing from, according to them, they are breathing. So we have to clearly tell it's the abdomen
Abdominal.
which has to
It's
come
very
out
important.
and
Yeah.
then in.
Yes.
And when they are pushing, sir, what we have noted is some patients are able to inspire, like the abdomen goes out and then expire. That's the time when it actually goes in. Now, that is the time we have to coordinate with relaxation or even push, isn't it, sir? It's when they're
Basically, what I do is I first ask them to relax and then push. It should be the because most of the teaching is relax, push and relax. It's difficult for them. So I ask them to initiate relaxation. I ask them when you sit. What I ask them is when you sit on the potty seat, first relax your, tighten it, relax it for 20 seconds. Take a deep breath, push down. This is what my final instructions are to the patient.
okay.
So the relaxation component I always keep before, and the push is second, because I feel once they are relaxing, the push, during push also they'll continue to relax.
Okay, this is important change, isn't it, sir? First, relax, and then the breath, the push the
Yes,
abdomen, all this in coordination.
yes.
Okay, so great. So also they say that diaphragmatic breathing as such plays a good important
Very
role.
important.
Like how do you suggest them as a prescription, sir? You have to do this breath this many times a day. This is what you'll have to do. Like anything, any tips on that, sir?
Basically, breathing exercises is there a lot of videos I ask them to download and see. From the sphincter point, what I do is so that they are a little sensitized. I say two components when they go home. Suppose I am looking at a patient with fecal incontinence. What I ask them to do is keep a watch in front and tighten the sphincter for 20 seconds, relax for 40 seconds, every day, 5 times a day, sitting, lying down, any position for at least 50 to 60 minutes in 24 hours. This is my instructions to patients with fecal incontinence.
Fecal incontinence.
Now, this is the home part because I feel that if they continue doing this, they get sensitized to that area and it helps them. Now, if you look at these patients with pelvic floor dyssynergia, I give them two separate sets of instructions. My first set of instruction is the same. Here I ask them to just tighten it for 5 seconds, keep a watch in front. Tighten for 5 seconds and let it loose for 60 seconds. Same, I ask them to do them 5 times a day, 10 minutes each time for 50 minutes in a day. And I asked them a separate set. I told them is when you're going to pass to, when you sit on your potty seat, first tighten, relax for 20 seconds, then take a deep breath and then push down, keeping the lower end relaxed. So, and I ask them not to do this when they are sitting in the room and all. It's basically only when they are passing stool. So, my thing, what I ask them to, the main purpose of it will help definitely in fecal incontinence because you are exercising your muscle, and it helps so that they get a bit sensitized. And I have seen it helps them overall.
Okay. Okay. So for both, the pattern of exercise is the same. Contract and relax. It's just the time which we have to strengthen.
Yes.
For it is more of relaxation for the first one and contraction for the second one. And
Yes.
accordingly, that 1 minute is changing which
Yes.
component is there, isn't it, sir?
Yes.
Superb, sir. Thank you. We can keep going on and on and on, but then we want to keep the most important information and keep it to our practice and do justice to the patient. So, really well elucidated, sir. All the points well taken from you. In case there are any doubts that few of the students put up in the WhatsApp group or anything, you're always there for guiding us. Thank you, sir. Sir, in our one more last doubt, sir. Almost 1 hour we'll have to sit with the patient and explain to them everything. Is there any way to actually instruct them, and then we can do a little bit of our work and then go back and then tell them, okay, you have learned this is good, now you do this? Is that
I'll tell
pattern?
you, I'll tell you practically what we can do.
Yes, sir.
What happens is, first day when the patient has come to you, I am there with the patient first time. Second time, what happens is I put this. I told you now, this timelines. My tech, I will be there initially. Then write in a paper that for first 15 seconds, it will be relaxation. Then 10 seconds breathing, 10 seconds. So I write that all, and usually I'll be coming in between the procedures saying, but first time I am there for 1 hour. Second, third time, once they understand, and if you have this set timelines, Kibai from this time to this time, he'll be doing this. Next 10 minutes, he'll be doing breathing. Next 10 minutes, abdominal thing. Next 10 minutes, push down. Next 10, 15 minutes, coordinate. So it's a 1 hour. We have a schedule.
Hmm.
And each hour also, then I split it for this much time for breathing, this much time for relaxation. So once that is written, now the patient understands. Most of them are educated. So once they understand, then somebody has just asked that what is the timelines you are looking at. So I'll tell you my timelines. Suppose I am looking at pelvic floor dyssynergia. Relaxation 15 seconds. So 15 seconds I ask them don't first just tighten, and then I ask them to relax. I just leave it like that. I say that you should see to it that there is no black speck coming there and the pressures are not increasing. Once that is done for 15 minutes, then the breathing, I ask them to take deep breath for 30 seconds, leave for 30 seconds. This will be for 10 minutes. Then when the next 10 minutes, when I ask them to tighten the abdominal muscles, initially first 5 minutes, I'll ask them to tighten for 5 to 10 seconds and then relax for the next 30 seconds. Sorry, next 50 seconds. So all my timelines are 1 minute. Bearing down also, initially first 5 minutes it will be 10 seconds bearing down and 50 seconds relaxation. Next 5 minutes it will be 20 seconds. So I gradually go up. And in the coordinated thing, what I do is, in one, like if I'm giving 1 minute, 10 seconds relaxation, then 10 seconds deep breathing, then deep breathing and push down for 20 seconds, and then relax for the rest of the time. So this is how I go about in my pelvic floor dyssynergia. While in fecal incontinence, it is the same. 20 seconds, 20 minutes initially, what I give is, initially the for 1 minute, I'll ask them to tighten for 20 to 30 seconds and relax. So this will go on. And when it comes to the stimulation that you have to do, that I do repeatedly so that they get sensitized. And the last part is also, we have to be around because you are putting in air into the balloon.
Cool, sir. So the timeline was also very important. Like it's our presence with the patient in the initial phase till they get
Very important.
educated.
Yes.
And then, of course, that 1 hour is not like completely for the patient. Of course, we can still do our work and still the patient is doing the
Yeah,
right.
second session you can do that because first session, once they understand, the our technician will be there with that, who is also trained for this. And if anything, and I'll be seeing intermittently.
Correct. Great, sir. Thank you. Thank you for spending your time on a precious Sunday evening with us and giving us so much gyan about such a nuanced topic so clearly, so crisp. We all enjoyed it, sir. Thank you. Thank you, sir.